Kia ora. I'm Holly from the Ovarian Cancer Foundation New Zealand, and I'm very excited to welcome you to this webinar on clinical trials. This will be presented by Dr. Michelle Wilson and facilitated by OCFNZ trustee, Dr. Alicia Didsbury. After they've presented, they'll have some time to answer questions. So if you're attending live, please submit them using the Q&A feature in your toolbar. If you wiggle your mouse or tap your screen, you should see it. You can submit your question at any stage, but we'll address them all at the end. Please note that this session will be recorded and you'll be able to watch it again later. Now I will hand you over to Alicia to get things started.
Kia ora, everybody. It's really great to be back again in the second part of our ovarian cancer research webinars. So we've really been looking at the landscape of ovarian cancer research in New Zealand. And last time we covered a little bit around lab-based research and what that looks like. And today we're going to do a little bit more of a deep dive into what clinical trials look like and we're going to explore a little bit more about that. And it's my absolute pleasure to introduce Dr. Michelle Wilson. Dr. Michelle is a medical oncologist at Auckland City Hospital, and she's also the clinical director for cancer and blood research. And just to give you a little bit of background about Michelle, Michelle is all of us researchers. She's our go-to person whenever we have any ideas around gynecological research that we might be doing or any clinical trial ideas. Everything goes through Michelle. She's the absolute hub in New Zealand for all this sort of stuff. And she's always available. She's always there, and we throw all our harebrained ideas at her, and she's very, very patient with us. So it's really a pleasure to have her here today to talk you guys through what ovarian cancer clinical trials look like in New Zealand, and we're going to learn a lot together. And just my usual disclaimer, we're not able to give any medical advice. I mean, obviously Michelle's a medical oncologist, but she's not able to give any advice on any of you guys' personal situations, but the best place to go is back to your own oncologist. But we're really happy to answer as many of any other questions that we can. So without any other mucking around, I'm going to hand you over to the wonderful Dr. Michelle Wilson.
So, oh gosh. Always happens. So kia ora, my name's Michelle. I'm a medical oncologist based in Auckland and very humbled to be here today to talk about clinical trials. Thank you for the very kind introduction, Alicia. And again, I think what makes this sort of space so exciting is that we get to work with phenomenal researchers from the whole landscape of cancer care. So my disclaimer is that these are my viewpoints and my knowledge, and whilst I do work a lot in this space, I don't know everything about this space. And again, there will be very open to any questions that we can answer as we go through. So I was asked to talk about clinical trials, and we are going to run through quite a sort of few different topics and questions tonight. I'm going to start with why trials matter, what types of trials there are, what happens behind the scenes. We get a lot of questions about that in our clinic. Try to unpack some of the terminology that we might use, and then think about what being involved in a clinical trial might involve. And then finish a little bit with about how do I find out more about trials. So I thought I'd start by talking about why research and trials are so important to me. So before I started working as an oncologist in Auckland, I spent 2 years in Toronto in Canada working at the Princess Margaret Cancer Centre. And I worked with this amazing group of people that you can see on the stairs here in a centre where everything was about research and trials. Basically, every facet of patient care had a question being asked. And again, there was just so much support along the process, looking at ways we could better diagnose people, ways we could better understand the cancer. And it wasn't just about treatments. It really highlighted to me the full role that research plays in getting us to where we are. And I think it's all about the people. And when we think about why do clinical trials matter, well, it's about that person sitting in front of you in clinic in their whānau. Everything we discuss in clinic has come from a trial of some sort or research of some sort in the past. There has been someone in the past who's been involved in some research of some sort that has led us to discuss why we might use a specific treatment, why we might use a different test. And again, that's what's so important. It's you. Every clinical trial that we do is being done with the aim of helping people live better and live longer. Now, again, it doesn't mean that every trial is successful, but we also learn from trials that are not successful as into what doesn't help people live better and longer. And again, some argue that you can almost learn more from some of the negative results we've had than some of the positive. So what is a clinical trial? And again, sometimes the word trial is not really the right word I like to use, but basically it's looking to try and find new ways to prevent, diagnose, or treat a disease. And it's to try and determine if these new options are better than what we already do. And sometimes what we do is better, but sometimes what we find is better. Or sometimes it's better in some people, but not in all. And the goal of the trial is to improve that whole spectrum of patient care. As an oncologist, I'm predominantly based on the treatment or the management trials that are involved. But again, I have been involved when I was in Canada with some of the preventative trials that were being undergone to try and, particularly in people who might have had a genetic predisposition, to try and reduce the chance of cancer. And I think that is the thing. We are one small part of the journey and pathway that people are on. So the international definition for clinical trials is that there are research that studies new tests, treatments to try and improve health outcomes. And the treatments are not just drugs. They are surgical procedures, radiology tests, devices, supportive care, preventative care, as well as behavioral treatments. They really do span patient treatments. And if you think about where do we need research, well, again, what we see in clinic, we have, I guess, a multitude of different types of ovarian cancer that we see, from high-grade serous to the more rarer epithelial ovarian cancer types to other even more rarer ovarian cancers. And when you think about it, we need research at each step in the pathway to continually strive to do better. And as I said, this can be from diagnosis, surgical techniques, to even the imaging and modalities that enable us to try and figure out whether we should do surgery or not. Treatment options, and that again starts from right up front, maintenance treatments through to recurrent disease. And again, quality of life and best supportive care research complements along the whole trajectory and pathway as well. And this has come, the antiemetics we use today with chemotherapy or post-surgery or with our anesthetics have all come from studies in the past. And they have, in general, improved significantly from when I first started working in this area. And again, we now do a lot more translational research as well alongside it. And the importance of this we'll come back to. And again, this is where we try and understand better who benefits from each of the treatments that we do or the interventions that we're looking at. Each thing we do in a study is put in there for a reason. Might be hard to tell at the time when you're undergoing different tests, but there is a reason and a rationale for why they're looking at it. So what types of clinical trials are there? Well, there are lots. So again, in terms of the difference between clinical trials versus observational studies. So clinical trials are where people in the study get assigned to one treatment or another. And these can be our randomized clinical trial. These can be studies where we actually don't, as a clinician looking after you in my clinic, I don't actually have a say in terms of which treatment you get. For observational studies, we don't assign people to a treatment or not, but we look at what the treatment does to a group of people to better understand it. So it's more of an observational study rather than allocating you to a treatment or not. In the clinical trials, there are multiple phases. And again, you'll have heard a little bit about the preclinical research and what goes on in the lab. There is a lot of work that goes on before a drug is brought to the clinic. And again, this, when you look up the literature, it varies in terms of how much time it takes, but this is in general years. And you have tens of thousands of compounds that go through a lot of early research, being tested on different sorts of cell lines, which are meant to mimic what ovarian cancer looks like before a drug gets moved through to the clinic. And then we have what we call our phase 1 studies. Now, phase 1 studies aren't available necessarily at all sites. It does require sort of dedicated phase 1 researchers, but a number of centres around the country do these. We're fortunate to have a phase 1 unit in Auckland, led by Dr. Sanjeev Deva. And again, these are small studies looking at the safety of the drug. But these are drugs that have already been through a lot of preclinical work before they get to the clinic. These studies start with very small doses and increase slowly to try and ensure we don't cause harm. But these are normally talking, 10 to 20 patients in these studies. If these look encouraging and the drug doesn't look to have too many side effects, it gets moved through to phase 2. And again, there is a bit of a blurry line between these nowadays, but basically this is looking to try and see if it works. So you get a signal of whether it works or not in the phase 1. And again, you've been starting this pathway right from the lab. But in phase 2, you're testing it in more people. You're always checking safety at each of the steps and trying to understand the side effects, because these do evolve and become more obvious as more people are on the studies. But you're looking to see if it works. And then if it works, it moves through to phase 3, which are much larger studies. And when it says more than 100, most of these are in the high hundreds to thousands of patients. And this is normally comparing it to what we already do. Because a treatment can work, but what we want to do is see if it works better than what we already do. And we also want to see how it is in terms of the impact on your quality of life or on the side effects compared to what we already do, to see if it's worth going to the next step. And this phase 3 is normally what leads to drug approval. And phase 4 is once the drug's already been approved typically, and looking at the actual impact in real life. So in the clinical trials, and we'll talk a little bit more about this, but there is often criteria that limit who can and can't go on to a study. Phase 4 is looking at what the study does in the real world, with where we might have other medical problems to deal with alongside the drugs, and just balancing that. So this is really important in terms of our actual practice. However, when you look at the number of drugs that process through this, it is, tens of thousands of drugs to get off into one drug approved, which can be a bit depressing, but it also highlights the safety of each of these steps, and the fact that, again, it does take time and a lot of research to try and improve and get that drug into the clinic. Phase 3 is predominantly what we see in New Zealand. I was also asked to talk about what different types of trials there are behind the scenes. So in terms of who runs the studies, so there are some studies that are run by pharma or drug companies. Now, these studies have often been designed internationally. They still have clinician input, but often international clinicians who are well recognized, often in the States or the UK. They define the trial. There are obviously a lot of work done with the companies in terms of what that study ends up looking like. These studies do have more support for people traveling to be involved in the trials. And again, they often are run internationally and recruit large numbers of people. In terms of investigator-initiated trials, these are the ones that you see come through our cooperative groups like ANZGOG. These are often led by the clinicians. They're often supported by grants, so they don't have as much funding as what the pharma studies do. So there is often less support in terms of things like traveling to be involved in the studies. But these also are really important in that, as a clinician here in New Zealand, we have more chance to be involved in, I guess, the design of these trials and trying to make sure that they're relevant to us than we do with the pharma-led studies. So there are challenges with clinical trials. So again, when we look at the clinical trials, we start with a group of people. And again, typically this is based on a diagnosis of some sort. And when I started working, again, basically we used to just use ovarian cancer in general. We've now got much smarter and we can break that down into different subgroups, but the same sort of treatment is given. The challenge with this is that there will be people in this group who get benefit from it, but they also get lots of side effects. And there will be other people who get no benefit and they get side effects, which again is not what we want to put anyone through with a clinical trial. Then there are people who have no benefit, but they also have no side effects. And then further still, we have people who get benefit and no side effects. Again, so this is the group we really want to be trying to figure out how we define that. And then we want to also figure out how we define how we know who's going to get side effects so we can potentially modify the doses. And the other thing with this is that even within that group, that benefit, there may be one patient who gets an exceptional response. And it's again by looking into the people who benefit, looking into those who don't benefit, that we can start directing treatments better. And this is what clinical trials are trying to do. There is no guarantee with a clinical trial that it will work. It will work for some, it will not work for others, and there is a risk of harm. And this is why there are so many steps to being involved in a clinical trial. But we're trying to do better as well. So we've talked about the different phases of clinical trials and how long it takes to get answers. We want to get more answers quicker for people in clinic. And so in terms of when we look at where clinical trial design is going, they're now starting to think about it rather than just based on one type of cancer and treating everybody the same, trying to differentiate it into the different groups based on biomarkers. And this is what we talk about as an umbrella trial, where you have one type of cancer, but you might know something more about that cancer and whether that might be, say, something like they've got a BRCA mutation or they've got some other mutation. And then we can use drugs that specifically target that to try and increase the chance of getting benefit in the trial and reduce the chance of people going through ineffective treatments. Again, these trials are designed based on what we know, which is why they often evolve with time. Basket trials are where you have multiple types of cancers, but you might have one common change. And this is an example of the Paragon trial, which is an ANZCOG study that is being run in New Zealand and also across Australia. And this is looking at patients with rare gynae cancers. Now, some of these cohorts have shut, so the ovarian and the endometrial cancer cohorts have closed already in terms of they've already recruited everyone to them that they needed to try and get answers. But this is looking at a simple test on the tumour itself, an ER receptor, to be eligible for the trial. They then do a blood test to look for a specific mutation to try and then direct the treatment to you. But this is enabling us to have more people involved with rare cancers in one study to get more answers. There are also things coming about called platform trials. So in these studies, you have your standard of care option, and then you have different options compared to this. And then if the treatment doesn't work, you stop that arm and keep going with enrolling people into the arms that seem to be working, or the treatments that seem to be working. And then as we learn more, rather than having to start over with a whole new study, which again, we'll talk about can take a long time to get to fruition, you add treatments to this one study, which means you're being much more adaptive and nimble. And again, it's also more cost effective in terms of getting these answers through to people quicker. So when I say it takes time, what happens before a trial opens? So there is a lot of stuff that happens behind the scenes before a study's open. I often get asked, well, how much longer? And sometimes I can't answer that question because there are so many different steps. So it starts off with a protocol. And again, the protocol has to be approved. And this is again through the people who are designing it. It can take months, sometimes even longer, to develop that protocol and to get people to agree on the key questions. And then as more knowledge evolves, that protocol might be revamped or changed to reflect that. And then after a study's been developed, again, they reach out to people and doctors across the country, across the world, to see who's interested in being involved in the study. And then we potentially get chosen to have our site involved. And that depends on how relevant that study is to us. Sometimes we get protocols that we don't think are relevant or asking the right question, or they don't have, the science doesn't make sense. And again, we always discuss this and think about this as a group. And then after that, the study then goes to ethics, and then that again can take time. And it's only once that whole process is done that we can actually open in clinic. And even between them and getting the first person enrolled in the trial, there's a whole lot of more practical steps, like making sure the drugs in the company, which in the country, which sounds simple, but sometimes it takes a long time to get drugs from one side of the world to the other. But yeah, so there are so many different steps behind the scenes. And it actually, again, from when we get selected to be involved to when we can open is often in the order of 3 months or so. And there is a lot of people behind the scenes making this possible. So whilst you see your doctor in clinic who talks to you about the trials, there is often a whole team of research staff who have been working behind the scenes to make this count and happen. And that includes coordinators, nursing staff. Again, we have accountants, pharmacists, we have different ethics boards and the people all involved in those ethics boards who spend, endless time working behind the scenes to make this possible. And I think when we, again, then once we present you with information about the trial, it can seem like a foreign language. There are a lot of terms that we use without meaning to that don't make sense. And again, sometimes I think about what are they actually trying to say. So the first thing that often comes up is informed consent. So when you're offered to be involved in a clinical trial, they might give you a patient information sheet to take away and read. This is often looks like a bit of a, definitely looks like it's written in different languages at times, but it's often, 30 plus pages, and it lists everything possible that we know of that could happen to some degree. And the thing is, it is really important to weigh up your options because clinical trials are normally one option that you can consider. And again, with clinical trials, for some of the treatments, some treatments are old, some are new, and for some of the drugs, there is still learning happening through these trials as they go on about potential risk, which is why sometimes you get asked to sign a consent form again because something else has come up. So you're aware of things as we learn about them too. The consent form has specific things that have to be included. And so ethics boards check that all of that is included. And that includes information about what happens to your tissue, to your blood tests. It has questions about not only the risks of the treatment that you're potentially going through, but the added tests. So things like the extra radiation exposure, because there is often more scans involved in clinical trials. The extra blood tests, or if some studies need a biopsy, not many, but some, and those additional risks are all included in there. It is often reviewed by multiple people before it gets approval, but it still can be really complicated. And again, the key thing is if you're thinking about a trial and there are parts that don't make sense, ask. Again, it's really key because there are things in there that are sometimes easier to talk about than read on a piece of paper. The other question that often comes up for me in clinic is why is there a placebo arm? And I think one of the key things is that whilst we can see that the drugs look promising, the key question is, are they better than what we already do? And whilst, again, that's what leads to changes in our clinic, but not all drugs are better than what we already do. And I've just taken this example from sarcoma. And again, this is a treatment, olaratumab, which is definitely a mouthful and a half. Try saying that 10 times fast. But that was used alongside a standard chemotherapy, doxorubicin. This actually got FDA approval based on earlier data suggesting it had made a massive improvement. But when they did the larger study and looked at it using a placebo, they found that it didn't actually help people live longer. And again, with additional side effects, it didn't help people live better. And so again, we could have assumed we were doing benefit. And that is the hard part, is that we know that sometimes our standard of care option is better. But the only way we can be certain is by doing trials, unfortunately, that include placebos. But again, it is hard if we know that but we never really know for certain if a treatment is better. The other thing is the protocol, and it really does look like those old telephone books we used to have. And again, this itself is often hundreds of pages, but it is what outlines the rationale for the study. It is what outlines the doses that we use for the study. It gives advice to the pharmacy team about how the drug's made up, as well as with complementary advice. It gives information about when you need to have scans and tests done. And again, this is the Bible that we go by when we're doing clinical trials. And so again, sometimes we might say to you, oh, we need to check things. This is what we're checking with and the study team. But the reason it's so important is that if we want to get to the drugs approved in the long term, it is all based on the quality of the trial that's done. And that is why the protocol detail is so relevant to making sure that no matter where you are in the world, you're doing things as closely together. Obviously, there will always be variations, but it's trying to keep it as close as possible. There are people behind the scenes and often just at the end that we can talk to as well. The other thing with clinical trials, and often people say to me, oh, but isn't that study in the cancer type I've got? But there is also lots of criteria listed in that big protocol that tells us who the study is right for and not right for. And so there are often inclusion criteria and exclusion criteria which we have to go to. Some of them are based on other medical problems, blood tests. They might be based on specific characteristics of the cancer. And again, one of the challenges for us is that these are increasing, the number of check boxes we have to tick. So this is actually looking at lung cancer trials, and this data is quite old now. But again, it's looking at over a 20-year period, the number of tick boxes that had to be ticked for a lung cancer medical oncology trials had nearly doubled. And I think the thing is the aim is to keep the treatments and trials as safe as possible. But it's also then makes it challenging for us thinking about the actual implications in the real world where we are practicing. But safety is key. So, what do you need to think about if you're considering being involved in a clinical trial? So, what does being involved in the trial look like? Well, initially, your doctor might raise it with you, or you might have asked your doctor about it. They then present you with information about the trial that you can take away and talk to your whānau, your support network about to see if it feels right for you. Then normally one of the research team will reach out to see if there's any questions that have been asked, and again, reinforce that whatever you choose is the right thing for you. Then people have to travel, unfortunately, normally to the hospital where the trial's been done. And then you normally meet with your doctor, or if it's been done through a special trials unit with a different doctor who goes through the paperwork and the consent form, answers any questions with you. You then move on to have specific tests, assuming it's still the right thing you want to do, and you sign the consent form. And this might be a blood test. It might be us, and typically it involves us sending a sample of the tumor that would be from your previous surgery or a previous biopsy. It's normally previous, not needing to do a new one. And then there's normally some sort of quality of life form that needs to be filled in. Then if it's a randomized trial, all the data gets entered in, we check that all the criteria are met, we sign off a whole lot of forms, and then we get told from a team often far away which treatment you've been allocated. And then hopefully the treatment starts very soon. But each of these steps takes time. So it's not something that you can say, I want to be involved in a clinical trial and it's going to start tomorrow. And that's why the trial team will often talk to you about the pros and cons of the trial versus a standard option, which can be started much quicker. And it is balancing unknown risks and benefits. And again, we do have exceptional responders on trials, but we also potentially have people who get more harm from a trial treatment. And these are the challenges that we have because we're balancing those and making sure that you've got enough information to make that decision. There's also other costs to being involved in a clinical trial. There are often a lot more visits. That comes with its own costs. It can impact in terms of if you have whānau or family bringing you in. And the uncertainty. I mean, there is uncertainty, and these factors actually, in all honesty, affect you whether you are on or off a trial, because every time you have clinic visits, that takes time, and there is always uncertainty. But again, in a clinical trial, sometimes this can feel greater. There is the travel costs, there is the costs of having time off work, and again, there is also known costs of extra tests as well as extra scans as well. Now, these costs in terms of extra tests and scans are not laid to you, but the costs that are to you are the time off work and the extra time in a hospital when you could not be in a hospital. And as much as I know people love seeing us in clinic, I completely understand that people don't want to see us in clinic all the time. The other question I often get asked is, why do they need my tissue or more blood work? And this comes back to when we think about trying to figure out who sits in which of these groups. And so, again, through using different translational research, so that's trying to understand the cancer often at a gene level through DNA research or sometimes blood-based research, we can try and identify those people who are getting the benefits. And potentially we might be able to identify those who are more prone to side effects. So there are research, not in our world specifically, but in the bowel cancer world that has led to them developing some urine tests and other tests that can identify if you're more at risk of getting side effects from one of their treatments. But also through these tests, and again, the challenge is that we can try and identify those who are going to get no benefit so that we can try and avoid not unnecessary treatment for the person involved in the trial, but unnecessary treatments for future generations who might be looking at this research. And that is hard because a lot of this will benefit future people. And again, a lot of what we do in clinic has been the benefit of what people have been through in the past in these clinical trials to date. So how do you find out more? Well, again, I'm going to mention briefly about ANZGOG. So ANZGOG is the Australia New Zealand Gynae Oncology Group. And this is a cooperative group which is based in Australia. It has representation from across both countries. It has medical oncologists, radiation oncologists, surgeons. It has pathologists, radiologists involved. It has everyone. It has a huge team of scientists behind, which Alicia is heavily involved with as well. And basically they conduct homegrown research. They support researchers getting studies off the ground, and they're a massive support. On their website, which again is, they have a whole section on research. And if you click on that and you click down to the ANZGOG trials, it lists all the trials that are currently recruiting. And again, this has come up with the endometrial cancer ones. At the moment, there are not that many in the ovarian cancer space, but this is constantly being updated and evolving. And there are studies being worked through across the pipeline in this space. We do have obviously the Paragon 2 study, and there are some other rare cancer low-grade serous studies at the moment, but this is constantly evolving. So if you want to look, this is a place to look for local opportunities. As part of it, it has investigator videos where one of the doctors involved, so this is Claire Scott, who is the chair of ANZGOG, and I've just taken a screenshot of the video that is on that website where she talks about the EPOC study. So the EPOC study is not one available in New Zealand, and I think this is mainly looking, this is in a rare ovarian cancer cohort, but again, you can hear more about the study from the people doing the research on these websites. It also has a whole lot of education information on this website, which again provides information like what we've talked a little bit about today, but from real international experts in this. And again, I think if you run down it, it covers most of the topics we've covered today, but possibly in a lot more detail with things you can read over and think about. And I think the main thing is ask. So the other question I get asked is, when should I consider a clinical trial? And really, if you're changing treatment or having any sort of change in plan, you should ask your doctor if there's a trial relevant to you. One of the big challenges for us in New Zealand is having enough trials. And at the moment, that is probably, it's the area we're working the hardest on, is increasing the number of trials. We're trying to increase the equity of access of clinical trials. But again, the key thing is asking your doctor. Ideally, everyone, it will be raised if there is one, but just to be certain, you can ask. If you ask, it doesn't mean you need to say yes. Just because there is a trial relevant doesn't mean it's the right thing for you, and it is always your choice. And I think when we think about important points to remember about trials, it is always your choice. It is voluntary, and you can change your mind anytime. Saying no to a trial does not impact being offered a trial in the future, and not all trials are right for everyone. Trials do not always offer better treatments, but the other thing is not all drugs and trials are new. Some trials we have are looking at repurposing drugs from other cancer types, or some of the trials we're doing, these drugs have been used a lot overseas, but not so much in New Zealand. So sometimes, even though it's a trial, these drugs are well considered. So again, we had a study recently in Auckland. This was in endometrial cancer, and it was comparing pembrolizumab, so an immunotherapy drug, with standard chemotherapy. So whilst it's a clinical trial, pembrolizumab has been used for years in New Zealand and other cancer types. So it's not a new drug, but what we're looking at it is for a new indication, so for a new treatment. And so that's also really important, because sometimes you can think, oh, these drugs no one's had them before, but they have. But again, it's still your choice. We have no control as clinicians, over what treatment you're given. And you are the most important part of the process. Again, that is why it is so important that you feel comfortable to ask the questions, and know that we're there to support you through the process. If we don't know the answers, we'll find out the answers for you. Because again, we want any involvement in a clinical trial. I mean, it's the same actually, in all honesty, for thinking about your standard treatment options. You need to feel that you've been given all that information and you feel well informed. Because again, it is always balancing it, the best options for you. So where are clinical trials heading? Wow, again, I think when we think about ovarian cancer, we have come so far in terms of our knowledge and understanding of it. But it means that we're ending up with smaller and smaller. It's really becoming a rare disease made up of so many different small patient groups. So we're trying to understand for each of them. And every time we learn something, we know we need to learn more. And again, that's what makes us exciting, but also daunting. And that's where I think the basket trials, the umbrella trials, and the platform studies are really going to be our way that we keep streamlining research moving forward. And again, I have to say that being involved with the Paragon 2 study has been, great in terms of creating more opportunities for patients where we have few treatment options sometimes, or we've had, because of the rarity of it, there's been not a lot of research going on. I also think the N of 1 study, so these are looking at the people who do really well. And whilst we talk about it in terms of a clinical trial perspective, there are also people in our clinic who have done really well on a chemotherapy as part of their standard of care that we weren't anticipating. We can also learn a lot from that person, not just the people involved in the clinical trials. And that is the thing, is that clinical research, yes, we're focused on clinical trials, but there is so much more to it and so much more we can learn in our everyday practice. So I just want to end by revisiting this question. Why do clinical trials matter? Well, it really is you. Everything we talk to you about in clinic has come from a clinical trial. Every answer we give to you is based on some sort of research that's been done. We might not be able to pull specific numbers, but it is everything that shaped what we do today in our clinic. And again, he tangata, he tangata, he tangata. It is the people, the people, the people. That is why we are trying to do more and get more studies. But I think the key thing, it is you that is the most important part of the process for us. Thank you.
Thanks so much, Michelle. So everybody, now you can understand why I love Michelle so much and why she's such a treasure for New Zealand, because you explained that so beautifully. And there was heaps of stuff that I just learned as well. So I'm going to have to pick your brains later about it. So I've got some questions for you, Michelle. I'll try not to make them too tricky, but what are some of the most common misconceptions about clinical trials that here's your opportunity now to clear up?
So I think some of the misconceptions is that trials should be left to a last, to when you've got no other options. And yes, we do explore clinical trials when we've got no other options, but I think the key thing is actually every step we can do better. And that's where more and more trials are coming in, and moving treatments earlier on in the process. So again, there's been a lot of hype internationally about targeting folate receptors in
Yeah.
ovarian cancer. And again, that's all started from using it and when the cancers come back and we don't have as many options. But now that's even, that's moving earlier. And again, every treatment we have, PARP inhibitors, again, revolutionized our world. They started as being looked at once the cancer had come back, and we now use them earlier. So again, I think it's that's probably one of the biggest misconceptions. I think the other thing is that trial treatments are better. I mean, they can definitely be better, and some of them are better, but we don't necessarily always know that, which is why we need placebo arms still, to make sure, because there have been actually, I gave you the olaratumab example, but bevacizumab in breast cancer
Yeah.
had the same thing. It was approved for use and then got revoked because it wasn't better. And so we also need to make sure we're not causing harm with our treatments as well. I think the key thing with trials is also knowing that sometimes people think that the companies are more important in terms of the process. You are more important in terms of the process. Whilst I showed you that we have this protocol that tells us what we have to do, we have to do it if it works. But if what you need is different, that's what we do, because it's about your safety. Other misconceptions? I think the word trial. I don't like the word trial. It's research. It's trying to understand. But yeah.
Yeah, look, you did a really, really good job about talking about informed consent. And I know that that's something that we belabor a lot, trying to get it right so that it's both informative but also accessible. Do you have any tips for people to get help with understanding some of the pros and cons and sort of distilling out that information? I know you said to ask, but sometimes time with an oncologist might be really limited.
Yeah.
What would be your tips on that?
Yeah. So again, I think depending on what trial it is, like I think on the ANSCOG trial website, if it's an ANSCOG trial, they have some more like the videos and stuff to actually hear someone else's viewpoint on the study
Yes.
can be useful. Um, we at Auckland have a research nurse who will reach out who can go through things with you. Sometimes talking through it with a friend or your GP can be useful, or if you're meeting a different clinical team, talking through it with your normal oncologist or your normal clinical team. I mean, time is always can be feel pressured, but these are things we also want to prioritize because we want you to feel you've got the time and the opportunity to make the decision that's right for you. And again, I think with trials, there is a lot of terminology in those consent forms, which we would love to get rid of, but we can't for different reasons. And sometimes I think it's just knowing that sometimes we find parts of it as confusing as you probably do. So it's really just talking through it and understanding it. And I think sometimes people do come in, and if sometimes people do find it just too overwhelming. And I think that's what we want to know. If it's just like, if you don't want to go onto the trial, that's fine. That's absolutely fine. But we want to make sure that it's not because just that consent form is overwhelming, because we want to just break down some of those barriers as well.
And so would people usually get that consent form to take home and discuss first, so it's not just a right, sign away and now you're on.
Absolutely. Yeah. So that is also something. Sometimes I'll talk to a patient about a trial and they're like, "Hey, I'll sign now." And you need to take it away and digest it, because you need time to think about actually, how is this going to work for me? Is this the right decision for me? And so normally, I mean, you need it. least 24 hours. It is often more like a week. So we normally would give you the information to take away, talk about it with your whānau, or with whoever you want to talk about it with. It might be close friends, it might be your doctor. And then we would normally try and bring you back to sign the consent form, often at least about a week later. It
Yeah,
does vary, but yeah, those are rough.
I like the idea of involving more of your community so that everybody's going along this journey with you, so you're getting the support that you need. I think that's such an important part of it that we sometimes overlook. So yeah, I think that's such a fantastic way of approaching it. So I mean, the informed consent part is one of the barriers, but what are some of the other barriers that prevent patients actually being able to access clinical trials, if this clinical trials are available?
Yeah. I mean, I think there are lots of, I mean, for us in New Zealand, the biggest barrier is having the study or having a study that's relevant to you. And then the next barriers are often um, the trials take a lot of time. And so for some people, I mean, that can be travel time, that can be time off work. So um, if the study isn't available in your centre, then travelling to somewhere else to be involved in a clinical trial, it can be quite a burden, particularly if, I mean, for one of the studies we had recently, it was 2 weekly visits. That's a lot of time to travel up to be here, if you're not in the city. We are looking at ways to try and change that. So one of the initiatives that I'm involved with is something called decentralized trials, which is trying to move trials to be closer to home. And we've been very lucky to work with the team in Dunedin with that Paragon study I mentioned. So we've been working with having the study open there. So our the people involved in the study do at the moment have to fly up to consent in Auckland, but everything else can be done locally. And I think those sorts of initiatives are going to start to remove the travel or the geographic boundaries that exist for some of the clinical trials at the moment. Awareness of clinical trials is a massive issue in terms of knowing what trials are available. And so I think ANZGOG website is useful. There is a national work going to make websites available for people across the country to access and your whānau to access to see what could be available. But again, that's a little way away, but it is a initiative in the works, I've been told. So hopefully not too far away.
Fingers crossed. We've got a question from one of our participants. Is there a way to access clinical trials in other parts of the world through New Zealand?
Yeah, that's hard. So we have had some people, for a lot of the places, if you want to, you can definitely find out about studies that are happening in other parts of the world. The challenge is often the funding to be involved in those studies. So some of the centres, like we have had people explore being involved in clinical trials in Australia. If you have Medicare access, then that will be covered. But often, sometimes if you don't, then you have to part self-fund it. And again, it can be expensive. We have had people who have travelled to the States and stuff to look at it. But again, it is can be quite a costly, not many, but it can be costly. It depends on what you're trying to access. There are good websites. So there's clinicaltrials.gov that lists all the trials that are happening internationally, and it has information about them. Some of the centres will have contacts that you can email to see if they take international people, but it is hard.
And then just to follow up on that, do your teams keep up with research going on in other parts of the world to be able to offer best practice in New Zealand?
Yeah, so I think we're very fortunate in terms of in our space. So we're a relatively small group of as a gynae team nationally in terms of radiation oncologists, surgeons, and medical oncologists. We're very fortunate in that we get to be involved with international conferences. So I have just come back from ANZGOG in Canberra last weekend, and again, where there are international speakers and updates. We have access to all the international conferences that are happening. We also have gynae cancer reviews that come up, which highlight articles that have been published in the literature every 3 months and stuff. So I think we're really lucky in being a small knit team, though, as well, that we have our own New Zealand Gynae Cancer Group, which meets regularly twice a year to also discuss practice changing treatments that are coming in and look at how it can be, as well as between it, because 6 monthly can sound like a long way apart. But it means that there's a good communication network to try and look at how these things are brought in nationally, because we want things to be equitable and accessible no matter where you live.
Yeah, and having sat in some of those meetings, I can absolutely vouch for the robust discussions that go on when talking about best practice. It's fantastic. Do we have any clinical trials open for low-grade serous at the moment in New Zealand? Did you mention them?
Yeah, so there's actually been a lot of activity in the low-grade serous space internationally, which is really exciting considering how little there had been for a while. So Paragon 2 has had a low-grade serous cohort on it, so a group of patients. And again, Paragon 2, I think, is going to close soon, sadly. We don't have a lot. Every time we want to put a patient on the study, we have to reach out and ask if there's any space left. There is also the RAMP 301 clinical trial that's just open. So that's a new study in low-grade serous ovarian cancer, which is comparing sort of a new combination of treatment versus it is randomized, so you don't have a say in terms of what treatment you get versus either chemotherapy or hormonal therapy, and there are specific criteria. So we do, and I believe there's also some studies in Christchurch, but I could be wrong on that. So
thanks. And
ask your oncologist.
Ask your oncologist, yeah.
Link you up. Yeah.
Well, actually, that leads me to my other question: is how do oncologists decide whether to offer a clinical trial to their patients or not?
It's normally by looking at that eligibility criteria. So, so before I can offer a clinical trial to someone, I need to make sure that it's potentially possible. So again, we have the study information. So if someone from another centre emails me to say, have you got any clinical trials in this space? We say, we've got this study. These are the criteria. Let us know. Because again, we don't want to offer something and take it away. So it's trying to make sure that it looks like it's the right study for that person before we offer it. Again, it's typically purely based on those criteria.
And what advice would you give to, and I think you've probably given it already, to patients who are really interested in getting involved in clinical trials? Is it really just reach out and sort of, scan the internet, have a look at what's happening in New Zealand?
Yeah, so I mean, I think there's different ways. Again, asking your doctors, looking at the internet, I think through the Ovarian Cancer Foundation.
Yes,
Some of the patient websites and stuff that are around. There is a lot of information about research that's going on. There's ways to get involved with, often through foundations is how we reach out if we're doing like patient surveys and other research to try and improve how we deliver care. So there's lots of avenues to explore. If sometimes the nursing team or your oncology team might be able to direct you to local resources as well. But I think, again, everyone's always keen to be reached out to or asked. So sometimes we just wish we could do more and offer more. But yeah.
And so this is sort of one last question for you. Sorry to keep you going for so long. But and this is actually a question from one of our participants, but also actually a question that I was going to ask is, what can we do to try and increase access, or to try and help you guys bring the trials in? One of our participants here has said, can we help with writing funding applications for research, or writing letters of support, etc. And then from us, from an organisational perspective, we really want to support all the work you're doing. So what do you think that we as an organisation, as a community, as patients can do to help increase clinical trials in New Zealand?
Well, I think it's never underestimate the value of your voice, because again, we as clinicians can talk about the value of research and things, but it's the people out there. So we did a survey, must have been about 8 years ago now, where we asked people across the country if they wanted research and trials. And again, it was an overwhelming yes. But we constantly, whenever we're trying to pitch for more research, show that picture that says patients want it and whānau want it. Because I guess for us, yes, again, we don't always have the grant writing expertise, but we try. But it's also people knowing that people want them or want the option is really important for us. And again, I think it's also raising awareness and education around what clinical trials are and how they work, and trying to get rid of some of the myths that exist out there. Yeah, any help's appreciated, but I think you guys already do an amazing job just doing what you're doing. Yeah.
That's awesome. Look, just Michelle, thank you so much for being with us tonight. We really appreciate it. And it's been such a great conversation to have with you. And we're so excited to have you here as well, because we really want to support you in all the hard work that you're doing. I know it's not a breeze all the time, and it involves a lot of late nights and a lot of early morning calls, et cetera, et cetera. So we really appreciate you, and appreciate the time that you've taken to talk to us tonight. Thank you so much.
Thank you. It's been a
pleasure. I'll hand it over to Holly to close up, I think.
Cool. Well, there is not much more to say, but I'll just reiterate, thank you so much to both Alicia and in particular to Dr. Wilson for your time and your expertise. It's really invaluable, and very excited to be able to share it. That is all from us. So happy day.